Hello, welcome back to my channel. If you are on a statin or been told that you need to go on a statin and you don't fully understand that, we're going to address that in this video today. I want to talk about the new 2026 Dyslipidemia Guidelines because this is probably one of the biggest mindset shifts that I've seen in a while when it comes to cholesterol treatment. And a lot of people still think like if my cholesterol isn't that high, why do I even need to be on a statin? But the new guideline is saying that we need to stop looking just at cholesterol as one number on a lab sheet and really start looking at the overall cardiovascular risk, how long someone has been exposed to certain atherogenic particles, whether there are hidden plaques, and also whether other markers like LP little a or ApoB are telling us a bigger story that we need to pay attention to. So this guideline document, which is what physicians, other healthcare practitioners use to help make informed decisions. It pulls together all the data that we have. And this particular update in the guidelines has literally changed the name from the blood cholesterol guidelines to the management of dyslipidemia guidelines. And this is because we really have known for a while, but have a bit more concrete data that shows us that LDL is not the only part of the conversation. We really need to be thinking beyond that. Now, if you are new to my channel, my name is Dr. Takova Wallace-Gay. I am a clinical pharmacist in primary care. I'm also an educator of medical and pharmacy students. And today I'm going to be breaking down the top 5 changes in the 2026 dyslipidemia guidelines, why they matter for you, and why statins are still some of the most misunderstood medications out there. Keep in mind, though, that this video is for educational purposes. It is not personal medical advice. So please, please, please talk with your own healthcare team before making any changes to your medications or before jumping to any grave conclusions. You have to make sure that you're taking your own personal situation into account. These are all kind of general things to consider. So let's get into it. Let's start with the biggest headline in that this guideline is more aggressive when it comes to what we're treating, how we're treating. It's more personalized, though, and also a bit more focused on the risk over time. So the first change is more of a conceptual one, but it does matter a lot. This is no longer just a guideline about cholesterol. It is now a guideline about dyslipidemia. And this really means that it's addressing not only your bad cholesterol or your LDL cholesterol, but also high triglyceride levels and something called lipoprotein A or LP little a. Those things matter because our heart risk, our cardiovascular risk does not just come from one lab value alone. You guys know that you can have a person whose LDL does not look that dramatic. It doesn't look that bad, but they still have some inherited risk of heart disease. They have a higher plaque burden, plaques within the arteries. They may have some other residual risk as well, like diabetes and other just kind of atherogenic particles in the bloodstream that make them at a higher risk of having cardiovascular events. And that's something that our standard lipid panel just can't tell us. And so why this matters, this is why some people might hear from their clinician that your cholesterol isn't terrible, it's not bad, but then their practitioner is still talking about putting them on treatment. And so here the question is no longer just, is your cholesterol high? It really is, what is your overall risk? And how much benefit could you get from lowering that risk earlier in life? Now, the second change is that we have something called PREVENT, which replaces the older pooled cohort equations. Now, you may not know this, but there is a calculator out there that you can use to calculate your risk of having a cardiovascular event within the next 10 years. And so as your clinicians, we often will use this to help inform us of whether you have a low risk, a moderate risk, or a high risk. And so now we have a new calculator for that. For primary prevention, the guidelines now recommend using the American Heart Association PREVENT ASCVD equations instead of the older calculations or equations that we used to use. And I will link that equation in the description box below. Again, you can use this at home to calculate your risk, but you're often going to need the guidance and the interpretation from your healthcare team to understand what this means, what these numbers mean, what it means for you in terms of treatment. But you can still look at this at home for yourself, or you can ask them when you go in, like, what is my prevent score? Is it low? Is it moderate? Is it high? And how does this, how did you use that to help inform my care? So those are questions that you can absolutely ask. So again, the Prevent ASCVD tool is going to be used for 10-year as well as 30-year risk assessment in adults who are age 30 to 79 years old. Now, this is important because the older tool didn't start at that young of an age. So now we can see younger adults who we can actually calculate their risk a little bit more clearly, because the older ones, the older calculators is what I mean. Younger adults, those 30 to 40, could sometimes look deceptively low in their risk over 10 years because the calculator wasn't really designed for people that were under the age of 40. But now we can kind of see that a little bit earlier. And that way, if there is any kind of like accumulating risk underneath the surface, we could potentially sniff that out a little bit earlier with this new calculator. Also, this guideline is using a framework called CPR, which stands for Calculate the Risk, using the Prevent tool, personalize the estimate based on factors not fully captured by the calculator. So that could be things like, do you have diabetes? Are you on medications for high blood pressure? Stuff like that. So calculate the risk, personalize it based on things that aren't fully captured in the calculator, and then reclassify when appropriate using things like coronary artery calcium score. So we would use these other risk enhancing factors to help inform that number that we get from the calculator. So this is going to be a lot more nuanced. It's more than just looking at the LDL number. It's more than just, looking even at certain risk, or trying to take a bunch of other things into consideration to get the most personalized and specific information that we can for each patient. So if someone is telling me, my cholesterol isn't even that high, then as a pharmacist, I'm not making the diagnosis. I'm not making any diagnosis. But when someone comes to me, and this happens very often where people are like, I don't understand why I need to be on a statin. I don't want to be on a statin. I can then frame the conversation a little bit more strategically. And I've been able to do that a bit in the past, but this evidence gives us even more of a platform to stand on, to be like, well, what does your long-term risk look like? Yes, you're okay right now, but what does your long-term risk look like based on all of these other factors? Your blood doesn't lie based on the blood tests that we have, LDL, as well as some of the other blood tests based on your other medical conditions that you have. What does your long-term risk look like? Do you have diabetes? Do you have chronic kidney disease? What about HIV? What is your family history? Do you have a high lipoprotein A? Do you have a positive coronary artery calcium score? All of those things can now be better incorporated into the conversation, and that is going to completely change the conversation and hopefully help change the mindset around whether or not a person is going to take a statin medication. Okay. Number 3, LDL goals are back, y'all. So when I was in pharmacy school, I remember we used to treat to an LDL goal. That is what I learned. And then my 4th year of pharmacy school, we had new guidelines that came out for treating cholesterol then. And it was that we weren't going to necessarily treat to a goal, that we were going to treat to a % reduction. And me and my classmates, acting like we had been practicing pharmacy for years and years, were like, this is absurd. We're no longer treating to a goal. How am I supposed to know? Like, I just remember us doing it and looking back on it now. I'm like, we knew nothing. We thought we knew everything. But it's funny though, because now we're back to goals, and I have always kind of favored goals. We treat to goals when it comes to diabetes and blood pressure and a lot of other things. And treating to a % reduction was not necessarily a bad thing, but it left a lot of ambiguity. And so now we're back to goals. These 2026 guidelines bring back the LDL calculated goal and the non-HDL goal to help guide what we're doing with therapy. And so if you're someone and we're treating for primary prevention, and if I haven't explained that already, primary prevention means that you have not had a cardiovascular event yet. You've not had a heart attack. You've not had a stroke, anything like that. And then secondary prevention means you have had one of those events and we're trying to prevent you from having another one. So for many people in that primary prevention bucket, if they are at borderline or an intermediate risk is what we'll look for, then their LDL goal will be less than 100. And again, that risk is going to come from the calculator. So we got to look at that calculator and see what their risk is. And then if they're at borderline or intermediate risk, then we're aiming for an LDL of less than 100. If they're at a high risk, then we're going to aim for an LDL goal of under 70. And then if this is someone who we're looking at secondary prevention, they've already had an event, or if they're at a very high risk, so secondary prevention or very high risk, then the LDL goal that we're looking for is under 55. And we have had this conversation with our students. This used to be a very common drug information question that I would give my students, because we would have some patients who we would get their LDL down to like 50, 45. And my students would be like, oh my gosh, their LDL is too low. And so the question would be, well, how low is too low for LDL? And really what the literature told us is that we can go really low and it's healthy. Like, we want that LDL number to be really low. And so I'm glad that we've caught up to that in the guidelines, and that now we're looking at people who have a really high risk or have already had an event, a heart attack, a stroke, something like that. We want their LDL to be under 55. So we're just trying to aim for as low as we can with that LDL. Now, this is going to be a big deal as well, because it makes our treatment a lot more concrete. So when we are recommending treatments for you, we're not only saying to ourselves, take a statin and here's your goal. We're saying, here's the goal, here's how far you are from it, and here's when we would need to intensify it. So perhaps we put you on a moderate dose statin, or what we call a moderate intensity statin, and you're almost at goal, but you're not quite there yet. And you've been on that dose for an adequate amount of time. That could be 6 months, that could be a year. Then we might go ahead and bump you up to a higher dose statin. Or if you're already on a higher dose statin and you haven't been able to reach that goal at the higher dose and you're tolerating that medication, then we might potentially add on a secondary therapy. And some of my colleagues will go ahead and add that secondary therapy up front, because there's also some data out there that shows that it's beneficial to do that. And so I'll talk about some of those therapies later in the video. Now, why this matters for you, this is really going to help you understand why a statin dose might be increased, or why another medication is going to get added on, even when your number has slightly improved, because improved is not going to be the same as at goal. And so now we're looking for getting you to a specific number that you can see, that you can remember, and that you know, versus like we want to get a certain percentage lower than what we were at baseline. And to be honest, sometimes baseline was just kind of hard to capture after a certain amount of time, depending on your medical chart and things like that. So that got kind of confusing for some people. Now, the fourth change is that this guideline is going to give a much stronger weight to additional testing. So, depending on your insurance and also your clinician, and if they are incorporating these changes as early adapters to guideline changes, it's going to depend on them as to whether or not they're going to get this additional testing for you. But you can always ask for it and see how much it's going to cost. But these guidelines recommend the lipoprotein little a, or LP little a, at least once in adulthood. It also states that if we have an elevated LP little a, then we're going to treat that as a risk enhancing factor between a certain level. And then if it's above a certain level, then we're definitely going to make sure that we enhance your treatment. The guideline also says that something called ApoB is going to be useful when LDL and non-HDL appear at goal. So let's just say your LDL kind of looks like it's at goal, or it's close to goal, but you might have some other risk there that we might be underestimating, especially if your triglyceride levels are still a little bit high, like over 200, or if you have diabetes, things like that. Then we might get this ApoB level and use that to help inform whether or not we still need to push therapy a little bit more for you. So again, it's a more specialized and individualized way to treat things. We're especially going to think about this in men who are 40 and up, and in women who are 45 years of age and up. So this is going to be how you can catch that person who thinks about it as, my cholesterol panel doesn't look that bad. But then when we look a little bit further, their inherited risk or their plaque burden kind of tells us otherwise. And so that's going to help us kind of fit their biology overall into their treatment regimen and not just look at the most familiar lab, which would normally be LDL. Now, the fifth and final change that I want to talk about is that we are looking for earlier treatment, more specialized populations, and clear guidance on when to add non-statin drugs. So the guideline really pushes for earlier actions and gives us a clear pathway for who may need treatment, even when the conversation used to be more hesitant. Like, should we add on this drug? Should we add on that drug? Like, what does the data tell us? So it supports earlier consideration of therapy in younger adults, especially if they have an LDL of 160 or higher, or if they have a very strong family history of premature cardiovascular disease. It also recommends LDL lowering therapy for primary prevention in adults who are 40 to 75 years of age with diabetes, stage 3 or 4 kidney disease, or HIV, regardless of LDL. So let me state that again. Primary prevention, you have not had an event yet, but you haven't had a heart event yet, like an MI or stroke, but you are between the ages of 40 and 75, and you have either diabetes, stage 3 or 4 kidney disease, or HIV. Regardless of what your LDL levels are, we're going to recommend to add therapy on there with a statin. And then if LDL is still not adequately lower with lifestyle, of course, as well as with your statin, then the guideline supports adding on something like ezetimibe or bempedoic acid or a PCSK9 inhibitor. And I will talk about those drugs in just a minute. And then finally, if someone has persistently high triglyceride levels, we're still going to use statins as our foundation. But just like with other guideline recommendations, we're going to add on therapy that could be with a fibrate drug to help support lowering those triglycerides and lowering your risk of pancreatitis. So one of the important nuances here that I want to state is that the American College of Cardiology specifically notes that there are certain medications like inclisiran, which is still being studied for outcomes in this context. So even though we know that it lowers the LDL really well, it's a good option for that, but they're still trying to figure out like how to fit it into the overall context of the treatment strategy. So what does that mean for you? This is when we can say to you, the guideline is stating that you need to start with lifestyle, then move to statins as a foundation when they are indicated, and then do not leave your higher risk patients undertreated if they are not reaching the goal. Go ahead and add something else on. So we don't just sit there and say, oh, we've got you on the highest dose statin. Like, we're not going to go anywhere from that. We're going to add something on for that. Now, because statins are not just for high cholesterol, I want to talk a bit about just statins in general and possibly where patients can understandably get confused. And really kind of this conversation that I have often. So statins, of course, are first and foremost, like this is what we primarily use them for, is LDL lowering medications. They inhibit a protein that helps with development of cholesterol. So we are blocking that from happening. We are reducing the amount of cholesterol that's being synthesized or made in the body. And therefore, we have to pull that cholesterol from the blood and use it in that way. So now we're getting the bad cholesterol out of the blood because we're not making cholesterol. The body's not able to make cholesterol. So that's their main job. But over time, the researchers, the PhDers out there have also described a lot of other benefits, things that we call pleiotropic or additional effects that these statins can have. And this really helps to explain why, we talk about statins so much and other benefits that they could have for individuals. So number one is that they potentially have anti-inflammatory effects. This is one of the most discussed additional benefits of statin therapy, and it is that they may have reduced vascular inflammation. So in older but very foundational work looking at statins, drugs like pravastatin lowered one of the inflammatory markers that we see in the body. And this was largely independent of LDL lowering. So it didn't matter about the LDL, it still helped lower that inflammatory marker. And so that's helpful for patients overall. And then we saw in another study that rosuvastatin, a different statin drug, lowered the LDL by about 50%, lowered the LDL by about 50%, but also lowered that same inflammatory marker by about 37 to 40%. And when we lower that inflammatory marker, it also helped reduce vascular events in people who did not even have a very high LDL at baseline, but they did have a high CRP, which is that inflammatory marker. So again, it proves that, or I should say, it doesn't prove that every statin benefit is cholesterol independent, but it absolutely supports the idea that looking only at the LDL definitely misses a part of the story, because there are other benefits there, including the reduction in these inflammatory markers that lead to vascular inflammation. The second thing is plaque stabilization. So this is a big concept with statins. They are thought to help make plaques in the artery less vulnerable. This is really important because those plaques can rupture or break off and travel, and then that's what leads to things like strokes and heart attacks. And so what we notice is that when we add statin therapy on, they can modify the plaque composition and really support regression, or reduction in that plaque, and also stabilization. So this just means that statins aren't just, again, they're not just lowering the LDL, but they're also helping to stabilize plaques that could potentially lead to other adverse cardiovascular events down the road. Number 3 is that potentially statins have a benefit in our what we call endothelial function. So statins have also been associated with improved endothelial function, and this is including effects on nitric oxide. Nitric oxide is a very potent vasodilator, or it opens up our vessels. And so this is going to matter because our endothelium, which is the lining of the blood vessels, we need that to be healthy. And if our endothelium is healthy, that means we have healthier vascular activity and vascular behavior. And so what we see with statins is that they help with vascular tone, they help with availability of nitric oxide, which also helps with vascular tone. And so we can see some benefits there as well. The fourth thing that we potentially see a benefit with statins are that people will say statins help with clotting or thrombosis. And mechanistically, this has been something that's proposed. Review articles kind of describe the antithrombotic effects of statins, but clinically, I don't really oversell this point. Like, I don't talk about this a lot with patients or ever. I'm just mentioning it here because we do have some information out there that suggested, and since I'm talking about potential benefits of statins, but there was a large meta-analysis of a bunch of randomized trials that did not really find a statistically significant or like a huge reduction in clotting events overall with statins versus control. So this is a good example where it's plausible, like this could happen, but we haven't really seen huge benefits. Just know in the back of your mind, you might see anti-clotting benefits with statins, but again, just take that one with a grain of salt. And then finally, when someone says that, my cholesterol isn't that high, again, why am I on this statin? I hear this all the time. The better answer is not because your cholesterol is bad. The better answer is more so because your overall cardiovascular risk may be high. So even though that LDL lowering, even though we want to lower your LDL, we might also be looking at inflammation reduction or plaque stabilization that could really have some meaningful benefits in reducing your chance of heart attack or stroke over time. And that's really where we're going. That's really what we need to think about when we're talking to patients. So I just want to briefly go over some of the medications and how they work as kind of like a cap off to this event, to this video, and then we'll leave it there. So I already kind of talked about statins. They help your liver pull more LDL or bad cholesterol out of the blood. This happens because it turns off the step in cholesterol creation, so that you can't make more cholesterol in the liver. But we need we need cholesterol for other functions of the body. And so if we're not making it ourselves, then we start to pull it from the blood and your liver uses it up. So now statins are again essentially stopping the creation of cholesterol in the body so that you're pulling it out of the bloodstream and using that LDL. Then we have a medication called ezetimibe. And ezetimibe lowers how much cholesterol gets absorbed from the gut. So we're just not able to, whenever we're eating or whatever, we're not absorbing as much cholesterol. We're essentially getting rid of it. Then there's a medication called bempedoic acid. And this medication works kind of upstream in this whole cholesterol creation or cholesterol synthesis process. And it is activated in the liver. This is one reason why it gets a lot of attention for patients who are statin intolerant, because it works a little bit above that and also activated in the liver. So if you can't take a statin, then you can use bempedoic acid, and essentially it's still going to help reduce the amount of cholesterol that's being synthesized or created. And then we've got a whole class of medications called PCSK9 monoclonal antibodies. These medications help prevent the LDL receptors from being broken down so that your body can clear more LDL. So we do have these receptors in our body. LDL binds to those. LDL, again, being our bad cholesterol. LDL binds to those. And then it uses it, like the body's able to use it. So we do have other things in our body that essentially breaks down these receptors or down regulates them. And so the PCSK9 drugs will prevent those receptors from being broken down so that we have more of them available to actually bind to the LDL and get it out of your body. And then we've got inclisiran, which I kind of nodded to earlier. This one uses a different mechanism. I'm not going to speak too much on it, but essentially it reduces PCSK9 production. And so again, PCSK9 being that thing that may break down the receptors, we are going to now reduce PCSK9 production. So the biggest takeaways here are that the 2026 guideline is asking us to stop thinking about just cholesterol. Is my cholesterol high? And really start to think about, what is my overall cardiovascular or heart risk? What is my LDL goal? And am I actually getting to that goal? And this guideline is a bit more personalized. It's definitely more aggressive for people that need it. And it gives us a little bit more clear guidance on what to do when statins aren't working, and what medications we could potentially add on. So once you go to your next doctor's appointment, if you want to ask your clinician questions, you might be asking, what is my LDL goal based on my risk? Because we would love to think that all of us clinicians are keeping up with all of the guidelines as soon as they come out, but that's not always the case. So it may take a little bit of time for people to catch up to the guidelines. So I think if you go in and ask some of these questions, it will prompt them to take a little bit of a deeper look into what's going on with your situation based on the newest evidence. So you can ask, what is my LDL goal based on my risk with the Prevent tool, which will be linked below? Do I need LP little a or ApoB checked? You can look those numbers up or ask them about it. As a pharmacist, I'm not going to be the best person to speak on LP little a or ApoB. Just know that they are markers that can help us note inflammation or other cardiovascular risk. You might also ask, would a coronary artery calcium scan change anything for me? And more clinicians are using the coronary artery calcium scan, more so I think in cardiology settings, but let's challenge our primary care docs to use it as well. And then also you might ask them, if I'm not at my goal on a statin or on this particular statin, what's the next step for me? Are we going to add something on? Do I need to amp up my dietary and lifestyle routine? So just getting an idea of what you need to do next. Hopefully this video was helpful. Again, it is education, not personal medical advice. So don't stop or start your cholesterol medication without talking to your healthcare team. And if this helped, just share it with someone, like the video, and comment below what your thoughts are about statins overall. Thanks for watching.